Hi, my name is Marc Bonaca, and it's an honor to present the STRIDE trial primary results, semaglutide and walking capacity in patients with symptomatic PAD. By way of background, peripheral artery disease is a prevalent condition impacting more than 230 million individuals globally. It's one of the earliest and most severe consequences of type 2 diabetes, and combined diabetes and PAD present a very clinically challenging condition with small vessel disease and disease below the knee, where functional impairment is significant and is a dominant morbidity. Now, we have class 1 indicated diabetes drugs in the guidelines, but none of them are preferred because neither have shown PAD specific benefits. And our only class 1 indicated therapy for function is cilostazol, based on a 40-meter improvement on a treadmill, but without cardiovascular benefits. And because it has a black box warning for heart failure, it's widely underutilized. Now, PAD is a complex pathobiology, as you can see on the left side of the slide, and inflammation, cardiometabolic disease, these all lead to an increased incidence of PAD, accelerated progression, atherosclerosis, and microvascular disease, and then progressive functional decline. Now, semaglutide and GLP-1 agonists have a host of demonstrated benefits, including cardiometabolic benefits, reductions in inflammations, benefits for MACE, kidney complications, and even in one study, a reduction in amputations. And so we asked the question of whether semaglutide in patients with symptomatic PAD would improve function, symptoms, hemodynamics, and lower the risk of revascularization or progressive disease. This is the STRIDE trial design. We enrolled patients who had claudication, diabetes, and peripheral artery disease, and randomized them to semaglutide 1 milligram weekly versus placebo. And we did robust assessments over the course of a year, including constant load treadmill at baseline, 26 weeks, 52 weeks, and then one test at 57 weeks after the last dose of therapy. We enrolled patients with early stage PAD, as you can see on the right, so Fontan 2A. So they had to be able to walk at least 200 meters, but they had to be limited and no more than 600 meters on an incline on the treadmill. They had to have abnormal ABI, and then we excluded patients with unstable cardiovascular conditions. Our outcomes are listed here in green. Primary outcome was function, so change in maximal walking distance from baseline to week 52. In orange, we have symptoms in terms of pain-free walking distance. We pre-specified quality of life using VascuQoL-6 and the SF-36 physical functioning domain. We looked at mechanism in terms of biomarkers and ABI, and then clinical impact in terms of outcomes. And the constant load treadmill was the primary endpoint. You can see that next to the 6-minute walk test. And just to put into context, it's about double the work when you walk on a 12% grade versus a flat surface at the same speed. And the constant load treadmill has no limit to distance. It's a true distance test, while the 6-minute walk test is a speed test. This is a global trial. We had patients enrolled in over 20 countries and 112 sites, and we enrolled about 800 patients. The trial had a robust ascertainment of endpoints. You can see over 93% completed the trial, and less than 10 were lost to follow-up in each arm. You can see our baseline characteristics here, and I'll highlight that this is a very common population you may see in your clinic with all the typical comorbidities. They did have a high degree of smoking, so you can see about 2/3 were current or former smokers, and then very high utilization of indicated medical therapies, including lipid-lowering and antithrombotics, and having a median LDL cholesterol that was 69 milligrams per deciliter, which was in tune with the guidelines. In terms of baseline function, you can see on this slide, they had abnormal hemodynamics, but I think what's most striking is even for early stage PAD, patients had a very limited maximal and pain-free walking distance, around 1/10 of a mile. And that was reflected in the quality of life on the right, where the overwhelming majority noted disability that was mild, and most with moderate or severe disability. All right, so the primary endpoint of STRIDE is shown here. And you can see in the gray bar, patients who were randomized to placebo had a slight improvement in function, likely due to the excellent medical care they were receiving and some drop into revascularization, as well as a learning effect on the treadmill. Semaglutide was superior. Benefit was apparent at 6 months, and the curves continued to diverge over the course of the 1 year of treatment. The delta that the patients appreciated in the context of semaglutide, the improvement was 40 meters as a mean improvement relative to placebo, and that's shown at the far right. We did a robust internal anchor measure to determine whether this difference was clinically impactful or clinically meaningful. And you can see here that this was highly statistically significant with a p-value of 0.002. So semaglutide improved function and of a magnitude that was clinically meaningful. In terms of subgroups, we saw that the benefits were consistent across age, sex, region, hemoglobin A1C, and importantly, BMI. Even people who had a lower BMI below the median had the same benefit. We also tried to understand a little bit of what mediated the benefit. So you can see here that body weight change was associated with an improvement in function. If you lose weight, you do walk a little bit better, but that relationship was extremely weak, with a Spearman's of around 1.2 to 1.4 in both groups. And that was too weak to explain the magnitude of benefit we observed in the trial. So it was not weight loss that drove this. We also saw improvements in A1C and blood pressure, as we would expect with this class of medication. Now, we looked at all the primary and secondary outcomes that were pre-specified, and in this trial, every single one of them was improved with a statistically significant p-value. In green, you can see that the various looks at function, whether it was on treatment, off treatment, symptoms in terms of pain-free walking distance were all significantly improved. Quality of life was significantly improved, both with the VASQ-6 and the SF-36, and we even saw a statistically significant improvement in ABI from around 0.76 or 0.77 to 0.81. Now, we asked the question of, did these benefits also come with a change in the course of disease, of progression of outcomes? And you can see on the left a composite that we looked at, which was people falling into the need for rescue, either revascularization or medication, a major adverse limb event, or mortality. And you can see that there was a 54% lower rate, and it was statistically significant with semaglutide. And on the right side of the slide, you can see the consistency amongst the different components of this endpoint. In terms of safety, SAEs were balanced between arms. There were more of the typical adverse events you'd expect with a GLP-1 agonist, including GI and appetite, but nothing severe like pancreatitis that was different between the arms. So overall consistent with the expected safety profile of semaglutide. So in summary, semaglutide in patients with symptomatic PAD now adds to the database of information for this drug class. This is a vascular drug. It improved function. It was clinically meaningful in terms of its impact. It improved symptoms and quality of life, reduced disease progression, improved ABI, and with a safety profile consistent with other studies. And so this now adds to the other benefits shown on the left side of the slide in terms of kidney, cardiovascular, and cardiometabolic benefits. So in conclusion, semaglutide is the first therapy to reduce major adverse cardiovascular events, improve cardiometabolic and kidney outcomes, and improve walking capacity, symptoms, and PAD or function-related quality of life in patients with peripheral artery disease and type 2 diabetes. On the right side of the slide, you can see now the circle around the leg or peripheral artery disease, which joins the other benefits across the cardiometabolic spectrum, across the cardiac, kidney, and other benefits of the drug. And it, I think, is an important finding for therapies where we always strive to make people feel better, function better, or survive better. And we now have a therapy in the vascular domain that can help our patients. Thank you for your attention.
Excellent. All right, so let's go back to the panel now and have some discussion about what we've just heard. Both Dr. Bonaca's and my talk. I'm going to start off with a very simple question. And I'm going to lob it first to Dr. Kadian-Dodov. When you talk to your patients with PAD, how do you get them until a trial like this one to take the standard medications, what is your conversation like about they're coming in with limb problems and you're giving them medicines for their heart?
Yeah, it's a fantastic question. I think it starts with the discussion that PAD is a manifestation of atherosclerosis, which is a total body disease, and that we know from the data that our patients with PAD are particularly at risk for the outcomes of MI and stroke. So we need to kind of attack it all with the medications that we have in order to prevent those outcomes. And by doing that, I think patients are on board with doing things like managing risk factors, blood pressure, cholesterol, diabetes, etc.
There are a bunch of different specialties on the call, and I was wondering if you guys would just tell the rest of the audience, what do you think your responsibility is as an interventionist, surgical, radiologic, or cardiovascular, in medical therapy for these patients? Is it the job of someone who's going to do revascularization to also make sure they have great medical therapy on board? Anybody can speak up first.
I'll start with that, and I think it's very important. A lot of times we see patients that we're not going to intervene on, but putting them on the right therapy, I think, is critical. I think it is our role, first of all, to check what medications they're taking. I'm being prepared to, add aspirin, add a statin, uh, make sure their blood pressure control is adequate. Making the call to their primary, making sure they know what you're changing, or asking them to make those changes. I think it's really important. A lot of times I tell my patients, hey, you're doing great. We're not going to do anything about what's going on right now, but really we want to prevent things from getting worse, and more importantly, heart attack and stroke. And that's usually those two buzzwords are the ones that make my patients listen a little better.
Josh, I would agree. I think that, many times as interventional cardiologists, we're the only cardiovascular specialists that many of these patients will see, and we are their panvascular doctors. And so, we are often on the hook to get them on optimal medical therapy and then continue to follow them. And we do that to the best of our ability. I think the question, though, that is relevant is the issue of polypharmacy. And, we know that the compliance of most of our patients is inversely proportionate to the number of meds they're on. And so as we layer on more and more complex therapies, we're going to have to prioritize those which we think are the most important, and then get down to the ones that we think are important but perhaps dispensable. And that's not necessarily a trivial discussion with these patients. We have less and less time to see patients and more education to provide them in the office. So, we often are reliant on our APPs, our nurse practitioners and physician assistants and other office staff to help with that kind of education. And that's, I think, part of the conversation we have to have. How do we execute on what we know is excellent medical therapy in the limited amount of time and with the limited resources we have? Not to mention the amount of time I spent doing pre-authorizations for some of these medications.
I'll
Ryan, how about you?
speak up in a second. Yeah, speaking maybe from a surgical perspective as a vascular surgeon, I think that unlike many of our non-surgeon interventionalists in the group, when you go into surgery residency after medical school, in some ways you sort of put all the medicines behind you and think that you're only going to do surgery and take this immediate active role in a patient's care. But certainly in vascular surgery and anyone who deals with cardiovascular disease, we just know that's a fallacy. And as vascular surgeons, we oftentimes spend a significant amount of our time serving as a primary care physician for a lot of our patients, unless they're well plugged in with a good internal medicine doctor, primary care doctor, cardiologist. Now, that said, what Sahil mentioned is really the problem. It's this problem of time, the time management, the ability to manage all of the different medications that we know are right for our patients. keeping up to date, especially those of us who don't go to a lot of the cardiology meetings, to keep up to date with the type of data that we're listening to tonight is a little bit difficult, I'd say. And so not only the issue of keeping up to date, having the time to talk to our patients, et cetera. And so the key that I've found, to the degree that I have been able to do this reasonably well, it's relying on some sort of protocols within your office and your practice that are often enacted by your APPs to really make sure that as the patients are getting ready for surgery, coordinating the discharge after the procedure or surgery, that you cover all of those bases. And that's it's an imperfect system, but again, to keep up with this field and all the needs of these very complex patients is tough. The one other point I'll make is that it's anyone who cares for cardiovascular disease in general and vascular patients. All of our vascular patients are at risk not only of PAD, but also of aneurysmal disease, carotid disease. So it's not hard for the patients and the providers to understand the link between all of these different disease states, but it's a different thing to actually enact best practices.
For me personally, I found that it's much easier to have this conversation, because if someone comes in and says my legs hurt when I walk, and I can say this medicine is going to help your legs feel better when you walk. They don't have to be in 8th grade math learning the transitive power, so that you're coming with a leg problem and I'm treating you for a heart problem, so to speak. So I think that I've used it as a way, as part of a conversation, to start using this medicine more often in these folks. But I agree with everybody here so far. We are now going to enter a point where we have to have systems in place to help us bring to bear all these medical therapies, because no one has time in a 12-minute session to have the appropriate conversation for the medications we're talking about. It's just not possible. Mark,
and
let me ask
Josh,
you,
can I chime in?
Yeah, please, Darren. Yes.
So I'm going to jump in and put the challenge to the panel and to the audience is, we've had evidence for GLP-1 receptor agonism efficacy for cardiovascular risk reduction since 2016. So we're 9 years into the data, and why are not sending a person out of your clinic without a prescription for a GLP-1 receptor agonist is like sending them out without a statin. So why is the vascular community so behind the times? We see these data. It's single digit prescription, and you'll see the data from SOUL. You just saw the data from STRIDE, but we've had the data for cardiovascular risk reduction for 9 years. So this is like a statin. It must be prescribed for every patient.
Yeah. Maybe I'll just comment. I mean, I think I totally agree with you, Darren, but and then I look at the data from Josh's, analysis from Best CLI, and a lot of patients aren't on the statin either. And I do think it speaks to some of the complexity of who's responsible for caring for these patients. And I'll make a couple comments. One, I do think, as Josh pointed out, drawing attention to limb benefits is helpful, because that's why people are coming to see you. But the second is to the interventional colleagues. We know in the coronary space, a lot more happens when somebody comes in and something happens to them, in their patient journey. They need a revascularization, they have an event. There's just a difference in the inertia around patient care. So they should be getting these in the clinic. But I also think that, when the team gets together around sort of, hey, someone's progressed or they've got symptoms, we're considering intervention, it's a good time to also think about medical therapy.
Darren, honestly, I think the answer to your question, and some of what you're going to address in your second talk, is that nobody in cardiovascular medicine, IR, or vascular surgery likes to give patients therapies with needles. We all avoided that by going into these specialties, and I think, it turns out that it's actually not really a big deal, and it's not like insulin. It's easily dosed. It's not hard to give, but I think that there was a huge upfront amount of friction, because you would tell them that they have to give themselves a shot, and you never had a bland face about it. You'd be like, you have to give yourself a shot, and that's the automatic indication for the patient to be like, I'm not sure. that is a flaw of ours. And in fact, I now think the tide has sort of switched where, I now tell patients, do you want to get on the medication that's the number one drug on the Upper East Side of Manhattan to keep people thin? And that sort of has them jumping forward. So I think, that is changing, but I think needles were the big problem, honestly. Not
Well,
who
and
great
access. Josh,
And
I
that's
think let's
interesting
be
to hear,
honest.
and Josh, and full disclosure, I take Ozempic. I have type 2 diabetes. I take Ozempic. You can't feel the needle. It's 35 gauge. You cannot feel it go into the skin. The fear of the needle is insane. And what I've heard is I've traveled around presenting the data I'll just show you about the tablet. Probably half of the patients who are resistant to taking an injection are resistant because the psychology of I'm so sick I have to have an injectable medicine, and so we now have an oral formulation. You'll see the data, but at the bottom line is these medicines are cardiovascular medicines, and to send a patient out from a clinic visit without one of these prescribed is like ignoring a statin. We've just got to catch up with the data. Vascular biologists,
Sahil, what were you
vascular
going
clinicians, cardiologists,
Yeah,
these are our
we're not
medicines.
really we're not talking about the real world, though, are we? I mean, maybe on the Upper East Side, Josh, but in Washington Heights, where I practice, it's a little bit of a different story. And again, the access to these medicines is not ubiquitous, even though they're approved and covered by many Medicaid plans. It is difficult to add the ninth medicine to the regimen. The guidelines have also not caught up. As you were talking about the role of low-dose rivaroxaban, it's only now catching on, in part because the guidelines take a decade to catch up with the data, and the guidelines do direct behavior. So I think that I'm guilty as charged. I may be one of those that isn't using it the way we use statins, but I see a lot of patients in the office, and I follow them longitudinally and as their doctor, and I have to make tough choices. So it's not an excuse, but it is an explanation. And I think we would be wise to try to find ways to overcome some of these impediments. I think that's really important to find solutions going forward for how do we incorporate this into the guidelines in a more real-time and rapid fashion. How do we disseminate the information properly, and how do we make it accessible to real patients?
But I don't think we have to rely on the guidelines. I mean, these are covered by third-party insurers for most people with indication. As I teach my trainees, the guidelines are for people who don't have the brains or time to read the literature. The evidence has been available since 2016. 2016.
Yep.
Yeah.
To
I
let
think
a
we all
patient
agree
leave
with you.
your
We need to
clinic,
bring the meds to
to
bear.
let a patient leave your clinic without you can prescribe it, maybe they can't get it, and I get that, but the fact that cardiologists and are not prescribing these medicines it's an embarrassment.
Yeah, Darren, I agree. I mean, but I do think it's not just in the vascular space, in cardiology in general. I think a lot of people have sort of resisted. Maybe these data help reframe, your data from SOUL and STRIDE, that these aren't diabetes drug with cardiovascular benefits. These are cardiovascular drugs. And the other thing I'll say, Sahil, I think you're totally right. There's polypharmacy, and we have to choose. And I have to say, I tend to think of like, if I can't prescribe everything, what's going to give you the biggest bang for the buck? And so then, I do think the data that we're talking about today helps prioritize, why you might use this earlier than you might have before, because you can actually make people live longer, feel better, you make their kidneys work better. There's their sleep apnea is better. There's all sorts of stuff. Plus people like losing weight if they need to. So maybe this helps disseminate some of that. But I think you're spot on that it's a complex problem, and polypharmacy is a real issue.
Yeah, I totally agree with that. And to the comment about nine pharmaceuticals prescribed, this class of medicines should rise above at least 7 of them.
All right, let's bring this. I want to bring this section to a close. I want to ask one more question of Marc. Mark, it looks like the curves continue to separate as the trial goes on. Silastazol peaked and plateaued. Do you think that the benefit will continue, the curves would continue to separate? Is that how it was looking in the trial?
Yeah, it's a great question. There's more to this than silastazol making you feel better. I mean, the ABI change is real, and the curves continue to diverge. And so I do believe that there's a disease modifying impact here. I don't think we saw any plateau. In fact, when people were off drug for 5 weeks, they still had better function. So I do think, and we didn't study it, but I do think the benefit is continual. And actually, I think Darren will show us in the next section of whether that translates into longer term, benefits in the legs. But I do think that the benefits would continue over time, and that this magnitude represents 1 year of therapy, not long term therapy.